The topic that we are going to be talking about today concerning the pediatric neurological conditions is spina bifida occulta with torticollis. It is by Brenda Guilandan and Tanya Garcia. Spina bifida occulta and torticollis. So my group had the opportunity to meet this week with a 5-year-old that was diagnosed with spina bifida occulta and torticollis at birth. Just to give you guys a little information in case you all don't already know, spina bifida occulta is a malformation of one or more vertebra. It is also known as closed spina bifida. There are other kinds of it. For spina bifida, there is open spina bifida, which is more severe. But in this patient's case, it actually causes no problems in most patients. Now, what was rare was that at the time that we saw him, I didn't know, but I came up with a few articles that said torticollis is rare in children that have spina bifida because when they're born with it, it is congenital. So it can cause bone problems or other symptoms. In this little boy's case, he had torticollis and he had a bone deformity on his right hand, which caused it to appear as if he had no wrist, and his hand was in an extremely exaggerated radial deviation position. So this little boy did not have a very severe developmental delay. He was actually very high functioning. But I do know that sometimes spina bifida occulta can cause behavioral developmental disorders. But again, in this little boy's case, it did not. He was very high functioning, and it did not seem like he was having a lot of trouble following his therapist's instructions. So in this slide, we talk about gross motor skills and milestones, which is the level in which our 5-year-old patient should have been at versus where he was actually at. So he should have been able to skip, hop on one foot, perform a one-legged squat, and catch a ball with his hands. Now, in our patient's case, he was not at the level he was supposed to be at. So his goals actually included jumping 3 feet and landing with both feet, because he had a tendency of landing one and then the other right behind it. He was not doing a one-legged squat because he couldn't even do a single leg stance yet. So that was actually one of his goals, to perform a single leg stance for 10 seconds. And he was working on it. He was at 5 seconds, but he had to do it without support, and he was still using support. He had to hop with both feet, and his endurance training, he had to run 40 feet in 7 seconds or less. So during our time at the clinic, we worked on the little boy's goals by performing different kinds of play therapy. We worked on his jumping and hopping with a basketball court. He had 2 rings on the floor, and he would have to jump from one ring to the other. They were placed around 2 or 3 feet apart. He had to throw the ball as he hopped to make it into the hoop. We also played the floor is lava. So we would ask him to stand on one of his legs and try to balance himself, or he would fall on the lava. It was really, really fun. And again, his goal was to make it to 10 seconds. We worked on his endurance training. We asked him to race alongside his therapist, which was Adrian. And we ended up running up and down stairs to slay a imaginary dragon that he had. And his developmental delay was expected to improve from his baseline evaluation. In evidence-based treatment strategy, one intervention that has always been proven to work best with children is play therapy. This includes toys, fun activities, obstacle courses, or things that a child can be involved in. The clinician should play with the child using age and developmental appropriate toys. It does not mean that the toys have to be for the child's specific age, but it should be for the child's current state of development. so that it's not too frustrating or too easy for the child. And it should be definitely something that they want to play with. So you kind of want to check before you start a session whether it's appropriate for him and whether it will have a positive effect. Because, for example, at some point when we were playing with this little boy, he would get bored and he just didn't want to do the activities anymore. So his therapist definitely had to keep making up very creative play therapy sessions for him.
The expected outcomes of play therapy are that children will engage in therapeutic activities because of the delivery in which those activities are executed. Because children will feel comfortable and safe in their environment, they will be likely to fully participate, resulting in positive emotional, cognitive, and physical development. Our patient demonstrated motivation, confidence, and determination through play therapy, and the goals were addressed through each activity. We noticed that through play, our patient would do a single leg stance for as long as he could in order to reach for a desired object. He would also hop on both feet at a distance, trying not to fall on, for example, the lava or something that was on the floor if he stepped on the wrong square or on the undesired length of distance. Our patient also worked on endurance by racing with the therapist, and we noticed that the therapist's attitude also had a very big impact on the play therapy. In order for positive results to be achieved, the play therapy had to be modified to the patient's needs and level of interest. For example, if the play was not at his level, if it was for someone younger or older, then the patient would not engage fully. As mentioned by two authors, Cole and Lawyer, as play becomes a creative outlet that blends imagination and reality, it becomes fun and absorbing. The therapeutic relationship is then deepened in play. No immediate treatment is needed for patients with spina bifida occulta, which is the form of spina bifida that our patient had. These patients usually do not need any surgery unless there's a tethered cord, which is a complication. It's a spinal cord is tied down and unable to move, and therefore they need to go in and release it. But this form of surgery is not common in spina bifida occulta. For torticollis, another form of treatment would be stretching. They could be rotational stretches or side bending stretches, usually placing objects such as toys on the neglected side and the child is forced to turn to that side. Tummy time is also very important for torticollis, and if need be, they might need to use a cranial remodeling helmet, but this is usually done at 12 months of age or younger. Parental involvement is crucial in patients with developmental delay. Parental involvement is needed in order to communicate between the therapist and the parent on what the child is doing at home, what difficulties they're having, and what they are interested in, so that the therapist can then create a form of play therapy that the child will be interested in, but will also address the developmental milestones and the goals. And it is important that parents are involved so that they can continue this form of therapy at home where the child spends most of their time. Our specific patient had right hand surgery at a very young age, and this surgery was done to correct a congenital deformity of their right hand, and at this time our patient was able to use their right hand more functionally, but they still needed to work on ranging the hand in order to correct the radial deviation. However, our patient was not on any orthotics for the hand at this time. Our group was able to observe a 5-year-old patient that was born with spina bifida occulta and torticollis. The patient presented with developmental delay and difficulty achieving some milestones. From working with this patient, we learned the importance of play therapy and how crucial the therapist's delivery of interventions is. With this patient, we played and engaged with the child in an environment that was fun and safe for him. It was evident how much the patient was enjoying therapy, and it was astonishing to us how he actually was working on each and every one of his goals while enjoying therapy to the fullest.